So we have a 63-year-old man presents to the emergency room for evaluation of severe chest discomfort that awoke him from sleep. The pain gradually resolved after 5 minutes when he sat up, recurred several minutes later. He's just not feeling very well for the past few days and comes to the emergency department. He has findings of a mild elevation of his temperature and a heart rate that's up. The heart sounds are normal. He's got a normal CKMB, normal troponin, total leukocyte count of 11,000, SED rate 55. Which of the following is the next best step? Cardiac MRI, prednisone, indomethacin, or TPA? Okay. Next question. Pericardiocentesis is recommended in which of the following situations? A post-cardiac operation pericardial effusion with a normal heart rate and blood pressure but respiratory variation in Doppler flow velocities, which Steve is going to go into. A young patient with chest pain, moderate-sized pericardial effusion, widened mediastinum on chest x-ray. A moderate-sized effusion with normal Doppler velocities, normal blood pressure, and a marked elevation of TSH. A small moderate-sized effusion in an asymptomatic breast cancer survivor 8 years after the last evidence of disease. Which of these would you do a pericardiocentesis and hopefully an echo-directed pericardiocentesis? All right.
We can improve on that.
They can improve on that. Which group of patients with constrictive pericarditis has the worst prognosis? Post-cardiac surgery, rheumatoid arthritis, tuberculosis, radiation. One more? Just one more.
I think so.
82% said radiation. And then a 72-year-old woman presents with a new moderate-sized pericardial effusion. She has hypertension, DJD, remote breast cancer treated with mastectomy 20 years. Which of the following is the best recommendation? Tap only if there's tamponade, tap if the effusion gets larger, tap for cytology, or treat with high-dose steroids?
I'll go back to that ECG later on.
You will.
Here we go.
Okay, take over.
Thanks. All right, so this is what it breaks down to on a typical board examination. About 3% of the board exam will have some mention of pericardial disease questions, which is going to amount to 5 to 7 throughout the course of a test. They generally are going to fall into those 4 categories. So those are the 4 categories that I will try to talk about in the time we have left this morning. So there is a guidelines document from the European Society of Cardiology that addresses management of pericardial disease, and much of this is based upon our experience at Mayo Clinic and then this document that our colleagues in Europe have put together. It's really a good document and goes through a lot of the ins and outs of pericardial disease in good detail. It's a great reference to have. So we're going to start off by talking about acute pericarditis and what we've learned and changed in practice over the last few years. So we all know this classic teaching that the typical features of acute pericarditis are chest pain, a rub, an ECG, plus or minus an effusion, and the presence of any 2 of those in the context of an appropriate clinical history is what you need to make a diagnosis. We typically have said you don't need an echo to make a diagnosis, although we end up getting an echo frequently, and in fact it is recommended just to make sure that there aren't major complications going on. It is due to inflammation of the pericardium. It's presumed to be viral in many cases, although obviously some abnormality of the immune modulation system is involved. Typically, again, diagnosed by a history of pleuritic pain, positional pain, a rub, ECG findings, and some marker of inflammation in the body. It is also recommended that we get cardiac biomarkers because of the potential coincidence of myocarditis with pericarditis or myopericarditis. And we want to make sure we're evaluating for that because that does change therapy in the approach to treatment to some degree. So go ahead and get the biomarkers, and typically your emergency department will have done you that favor already. So one of the things that the European guidelines talk about is understanding predictors of poor prognosis in acute pericarditis, because it does have some impact on how you're going to treat the patient. Can you treat them as an outpatient or an inpatient is the main thing. So if they're febrile, have a big pericardial effusion, they've got tamponade physiology, or if they have the troponin elevated, they're already immunosuppressed, if they've had trauma or they're on anticoagulation, all those patients have criteria for poor prognosis. The other one being if they don't respond to the therapies you start within a week. And if they have any of those features, then you're going to want to manage them in the hospital just because they're felt to be a little bit more precarious and you want to watch them a little bit closer. If they don't have any of these things to begin with, then you're going to go ahead and treat them as an outpatient with empiric non-steroidal regimen that we'll talk about in the coming slides, and then see how they do. If they respond to therapy, super. Just go ahead and complete their course that you've set them on. If they don't respond, then they become a moderate risk individual, and you might want to make sure you're looking for an underlying etiology that you didn't consider the first go-round. So the typical regimen that we now recommend is a non-steroidal for a couple of weeks and colchicine for 3 months. And it's based on the curve that you see on this slide, and that is patients who are treated with colchicine have better recurrence-free survival from pericarditis. And so go ahead and use colchicine as one of the first-line agents. We want to avoid corticosteroids in acute pericarditis because there tends to be a high rate of recurrence when you try to taper them from the steroids. We will talk about in a couple of slides the times when you do want to add steroids and how you handle that as you go through tapering them. But this is the first-line therapy. Said another way, to give you more specific recommendations, you're going to want to choose one agent from each of these two boxes. Since there's only one agent in the second box, that means it's colchicine. But you can use something like aspirin. Nish really loves to use aspirin, I think because he loves to be able to teach fellows about increasing the dose until people get ringing in their ears and then cutting back. But ibuprofen can be used, indomethacin can be used, but you want to start them on therapy for at least 1 to 2 weeks. There is some mention in these guidelines about following CRP as a way to determine whether the patient's inflammatory response is decreasing, and maybe you can cut off their non-steroidal, the first box therapy, with that as the CRP starts to drop, but you're still going to want to continue the colchicine for 3 months to try to decrease the occurrence of recurrent pericarditis. So that's what this slide is about. We'll walk through this. So recurrent pericarditis is someone who keeps on getting flares of pericarditis, either just as you're tapering them from their other drug or shortly after you've stopped the colchicine, they keep on getting flares of pericarditis. And the way you want to change your approach to these patients is now you're definitely going to use CRP to guide when you stop the non-steroidal drugs. So you're going to put them on, they're going to be on therapy for weeks to months in this case, and guide by CRP. If they are responding to that therapy, the first thing you do again is taper the non-steroidal over a few weeks and keep them on colchicine for another 6 months. If they don't respond to this, or if they get a flare from here, that's when you consider adding a corticosteroid for the management of recurrent pericarditis. Not first-time pericarditis or sporadic pericarditis, but for truly recurrent pericarditis. And then so they're basically going to be on triple therapy in this case. And again, if they have successful therapy, their symptoms resolve on triple therapy, then you're going to taper their steroid, but you may take half a year or longer to taper them off of their steroid. And the key is Often, particularly when you get below 20 milligrams of steroid, as you go down to a dose increment, they may get a little flare of pain, and you have to coach your patients to say, you may get some symptoms over the next 2 or 3 days. Stick with it because it'll come down. But if you re-escalate the dose of steroid every time they get a flare of pain, it's going to set that pattern in place, and you're going to bounce around a lot. So when you get to the lower doses of steroids, coach your patients that they may get some discomfort. It should resolve in 2 to 3 days, and try to continue them on the slow downward trend. Once you've tapered the steroid, then you taper the non-steroidal agent, and then again, after a couple of months, you stop the colchicine. For people who aren't responding to triple therapy, and this is a potentially testable question, not about dosing, but this is when you might start consider immunomodulating agents like IVIG, this anakinra, or azathioprine, to really smack their immune response to decrease this. Again, you're going to be guarded by CRT. You're going to taper one agent at a time, and it's going to be a long, long therapy. This is not something that's going to be done by the end of next month. So recurrent pericarditis can be very difficult, and in rare cases, pericardiectomy may be required, but that gets to be a little bit problematic because sometimes you can take the pericardium off and then they still have chest pain afterwards because they still have, some minor inflammation, irritation, some epicarditis that can go on. And so this is not a quick answer for patients either. If you have a patient presenting with acute pericarditis and their troponin is elevated, then you're worried about myopericarditis. If the history is right, the age group is right, the demographics are right, you're also going to make sure they aren't having acute coronary syndrome. But the idea is, if the troponin is elevated, you want to get an MRI to confirm, is it indeed a thick pericardium with inflammation? Is there a minor layer of inflammation in the epicardium, or is there a lot of inflammation that this is actually fulminant myocarditis with pericarditis on top of it? Because then you're going to treat it like myocarditis. But so get this, but the issue is you're going to hospitalize these patients and be more aggressive with their therapy. And it's potentially testable for a question that if this was someone, I was asked this question last year, if they were in the military or if they were an athlete, they're actually going to be told to not participate or compete at the highest levels for 6 months after the onset of this disease because there's such an arrhythmia risk if there's myocarditis involved. So the MRI you get if the troponin is elevated. So for acute pericarditis, it's always a non-steroidal plus colchicine. If the troponin is elevated, you're going to get an MRI. If they have recurrent pericarditis, remember to use CRP guidance for tapering 2 or 3 agents, depending on how many they require to treat that disease. Now, we're going to switch gears entirely to talk about pericardial effusions. So we all know, we've all been taught that pericardial effusions can be large, they can be small. They cause tamponade if they occur quickly, but giant effusions, if they accumulate over a long time, don't necessarily compromise cardiac function. A point about Doppler echocardiography. It is a super sensitive tool to the hemodynamics that are going on in the heart. But just because the Doppler things are changing, they're going up and down, the mitral inflow is changing, doesn't mean you need to jump in and stick a needle in someone's chest. If they feel fine clinically and they have a normal blood pressure, just because they have some subtle Doppler variation, that can be preclinical signs. It means you want to watch them closer, but you don't have to jump in with an invasive procedure just because their Doppler is varying. But if they have fulminant clinical pericardial tamponade, that is, they're hypotensive, they're fatigued, they're tachycardic, they have signs of pericardial tamponade that you can detect without the Doppler, then that's probably the kind of patient who you're going to want to consider pericardiocentesis. Now, pericardial effusions, the classic signs are the RV is compressed indiastole when it's supposed to be getting bigger. You can see the free wall of the right atrium kind of wiggling because right atrial pressure and pericardial pressure are the same, so that right atrial wall never quite expands. The IVC is going to be big, and it won't it won't collapse as the patient sniffs or inhales. And then you can sometimes see the septum shifting abnormally. This is just a still frame of a short axis of an echocardiogram showing the left ventricle here, the right ventricle here. It should be filling the space, but instead it's collapsed and concave because the pressure here in the pericardial space is higher than the RV pressure is. And this is what an M mode looks like. So again, late diastolic collapse of the RV free wall because the pressure is too high in the pericardium. You do pericardiocentesis if there are clinical signs of tamponade, or if you need the fluid to make a diagnosis. You don't do it if there's any suggestion of aortic dissection, because ascending aortic dissection can obviously dissect retrograde and can be dumping blood into the pericardial space, and if you relieve that blood, you're basically relieving the aorta of blood at the same time and probably not going to be a good outcome. Constriction and restriction. Okay. We told you this was going to come. We're going to spend a little bit of time talking about it now. There is an overlap in the middle. We talked about radiation therapy being one of the worst forms of constriction you can get, and that's because radiation therapy can cause constriction, restriction, coronary and valve disease all at the same time, and probably all to a little bit in every patient. It just depends on which one predominates. But there are obviously some people who have pure constriction and some people who have pure restriction. And how do we tell those apart? It's really difficult based on history. It can be difficult based on physical examination. So we're going to talk about how we do this. Constrictive pericarditis is a right heart failure syndrome. So they often will have signs of peripheral edema that's just dramatic, ascites that's dramatic. They'll have neck veins that we'll show you an example of. They don't have a lot of left heart failure signs. It's actually more of a right heart failure symptom. JVP is up in most of the patients. Again, peripheral edema, large liver. 47% pericardial knock. That means Nishimura is doing the examination. Most of us don't hear pericardial knocks that often. Most of the time, these are the three most common causes of constrictive pericarditis in our history. They've had prior cardiac surgery, it's idiopathic, or they've had prior pericarditis that's been recurrent. Then you can see some of the others: radiation therapy, infection, etc. Here is a neck vein of a patient with constrictive pericarditis. Yes, his JVP is really high, but the thing that you really notice about this is how quickly that collapses. He has really prominent descent. So when in the Y descent, when the tricuspid valve opens, that's the only time blood can really get down into the right ventricle, and so the neck vein just collapses as that blood flows in there. So when we look at constrictive pericarditis, we always want to get a chest x-ray. We almost always have an echocardiogram, and a CT is often used, although the MRI is sometimes being used to replace that, so these two are actually interchangeable now. Cardiac cath and surgical exploration, special case circumstances. In about 25% of the cases, it's probably decreasing. You can see pericardial calcification. This is a lateral chest x-ray. It's typically been associated with tuberculous pericarditis when you see that kind of calcification, though that's not a pure one-to-one relationship. And here's a CT scan showing a thick pericardium, but note this: 1 in 5 cases will not have a thick pericardium. So if you think the patient has constrictive pericarditis and the CT scan does not show a thick pericardium, that doesn't mean that you were wrong. It just means you have some more work to do to prove it. These are the classic hemodynamic tracings. As I mentioned before, it's kind of hard to distinguish one from the other. They both have a very prominent early diastolic dip and a plateau or square root sign. Difficult to look at a single cardiac cycle and say, is that constriction or restriction? So let's talk through that, because again, they like to test that. This is the same slide I showed in the earlier lecture when we were talking about restrictive cardiomyopathy. You almost want to put a big X through this slide in your syllabus because of the fact that these criteria are classic and historic and of note, but when put to the test, while group statistics would suggest there's a difference in these things between constriction and restriction, individual data points means it's hard for you to decide. So if the LV EDP and RV EDP, in restriction, this is supposed to be at least 5 higher. In constriction, they're supposed to be equal, but any single data point could have gone in either category, constriction or restriction. So group statistics would suggest there's differences in these things. Individual point estimates for individual patients make these not so useful, these classic criteria. And so let's talk about how we really diagnose it, because we're not going to send every patient to cath to look at these things since they're not that useful. The thing that we want to look for is this dynamic interaction that we see with constriction. With constrictive pericarditis, the hemodynamics are dynamic and change with respiration. And so we're going to look for something called dissociation between intrathoracic and intracardiac pressures, and we're going to look for enhanced ventricular interaction. So what this is talking about is the fact that in the normal situation, our heart sits in the thoracic cavity. The pulmonary vessels are in the thoracic cavity. When you take a breath in, the air rushes in because you're dropping intrathoracic pressure. The pulmonary venous pressure and the left atrial pressure also decrease, but they decrease at the same time with one another, so the driving pressure from the pulmonary veins into the left atrium is the same in the normal circumstance. When you have a big, thick pericardium in constriction, you're somewhat partially insulating the cardiac structures from the changes of pressure in the intrathoracic cavity. So when you take your breath in, pulmonary venous pressure drops, but left atrial pressure stays up, and so you don't have as much driving pressure for the pulmonary veins to empty into the left atrium. Couple that with the right side of the heart where the IVC is sitting outside the thoracic cavity and having a high pressure, you drop into thoracic pressure, you take that breath in, and all this blood comes rushing out of the IVC into the right heart. So when you take a breath in, you totally load the right heart, you underload the left heart, and so you see this dissociation between the intrathoracic pressures, wedge pressures going down, but left atrial pressure staying high. That's dissociation between intrathoracic and intracardiac pressures. The ventricular interaction is because the cardiac space is fixed now with this thing, you've increased right ventricular filling, you therefore are also decreasing left heart filling, so the ventricles fill differentially. I've got a great graphic that Dr. O put together in the next one that kind of describes this. So this is the situation. We're just going to show, this is the left atrium, pulmonary veins, and what the pulmonary venous relative Doppler velocities will look like. This is the mitral inflow. Here's the hepatic vein and the tricuspid inflow. So as you take a breath in and drop that intrathoracic pressure, so we've decreased filling from the pulmonary veins. The IVC now is going to really load because it's got high pressures in the abdominal cavity and low pressures in the intrathoracic cavity, so you're going to enhance filling in the RV and decrease filling in the LV. And that's going to move that intraventricular septum over, and so you're going to see enhanced right ventricular velocities and decreased left ventricular velocities. When you exhale, which is a preferable term to me than expire, the opposite occurs. You increase intrathoracic pressures, so the pulmonary venous pressures get much higher than left atrial pressure, and now you're enhancing left heart filling while the right heart is not filling as well. That is the pathophysiology that's undergoing that whole phenomenon. So what you'll see in the mitral inflow is you'll see a change in the peak E velocity by 25% between inspiration and expiration, or exhalation. You'll see the opposite change, but 25% change in tricuspid velocities between exhalation and inspiration. You can see that in the pulmonary veins and hepatic veins. We typically don't look at pulmonary veins because they're such hard signals to get. On the echo boards, they'll test you on hepatic veins. On the general cardiology boards, they will not. The idea is that you see this dynamic phasic change in mitral and tricuspid velocities because of this dissociation of intrathoracic and intracardiac pressures. Now, the other thing that's really important is this tissue Doppler thing. So remember, when the heart contracts, the base moves towards the apex. And then the base recoils in two motions in diastole. And we have now started measuring that for the last 15 years with tissue Doppler of the mitral annulus. And in the normal situation, you can see it on this bottom panel here. There's an early diastolic relaxation when the mitral valve opens, and then when the atrium contracts. When you have a myopathic process, you have dilated cardiomyopathy or you have restrictive cardiomyopathy, that early diastolic velocity becomes much lower. If this is about 8 to 10 centimeters per second, this is 3 to 5 centimeters per second. And it doesn't recover, it doesn't pseudo-normalize, if you remember that term. Once the muscle is sick, the muscle is effective, it doesn't have that recoil velocity. But oddly, in constriction, that early diastolic velocity is much more rapid than typical because the heart isn't expanding laterally at all. The only way the heart can fill is with enhanced longitudinal motion, and so the early tissue Doppler velocity is super fast. So you have someone with heart failure symptoms, and they might have a Doppler pattern that has the high E and low A that I talked about for restrictive cardiomyopathy, but rather than having impaired myocardial relaxation, it looks like it's enhanced. Dr. O has called this annulus paradoxus as a sign of constrictive pericarditis, and it actually is really a good determiner of whether the patient has constriction or not. So you see the phasic changes, and you see a super fast E prime velocity or early diastolic tissue Doppler velocity, you are really down the pathway a long way to constriction. Now, many patients still end up at the cath lab, and I think that is perfectly acceptable because this is an important distinction, because as I mentioned before, if they have restrictive physiology, there aren't a lot of great therapies for them. If they have constrictive pericarditis, they might get dramatically better with a pericardiectomy. That's an important distinction, a 5-hour operation versus consideration of transplantation. So we need to make sure we understand what's going on, and you might get a strip like this from Nishimura when he's doing the hemodynamic cath, and is this constriction or restriction? I said it was hard to tell because they both have dip and plateau. What you want to look at is the relative size of the LV tracing and the RV tracing here. So if you go from exhalation to inhalation, the LV looks smaller, and the RV looks like it's getting bigger, just the area under the curve. And if that's the case, if the LV is getting smaller when the RV is getting bigger, that's that enhanced ventricular interaction, that's constrictive pericarditis. If they're both getting smaller at the same time and getting bigger at the same time, that's muscle disease. That's restriction. So if there's a discordance between the size, enhanced ventricular interaction, constriction, if there is concordance, that's restriction. It means the pericardium's normal. And so that's the ultimate invasive hemodynamic way to tell. Not all this stuff between 5 millimeters difference in EDP or 1/3 RVSP, all those kind of things. You want to look for, with constriction, either dynamic phases where RV and LV are going opposite direction, either in the echo lab or the cath lab, and is the tissue Doppler E prime velocity super fast. And if you have those things, then we're talking about constriction. So, respiratory variation on Doppler, the ventricular interdependence, normal E prime and probably normal strain in constriction. BNP is also not usually super high in a constrictive patient, where it tends to be higher in a restrictive patient. And also constriction doesn't have the massive atrial enlargement that you can see with restriction. All clues to diagnosing constrictive pericarditis, for which there is a very good therapy in terms of relieving their symptoms, and that is a pericardiectomy. It is really the only way to treat chronic pericarditis. Constrictive pericarditis is with a pericardiectomy. It is highly effective, but it has to be a complete pericardiectomy. Little windows, little segmental resections might work temporarily, but then it doesn't work over time. So you really have to have a surgeon who wants to spend 5 hours peeling this rind off of the heart. And then as they do that, I don't have the movie anymore, but you can see the heart trying to expand out of the incisions they make because it wants to be free from this case. Now, there is the special case of acute transient effusive constrictive pericarditis that we sometimes see post-op from after cardiac surgery. If they have its approximate cause, an inciting event, and they have effusion plus evidence of constriction, this is another case where you want to use steroids, because if you jump on that with steroids early and then taper them, you can avoid a chronic constriction case in those situations. So that's the one other time that steroids become useful other than the recurrent pericarditis patient. So, we're going to think constriction if there is right heart failure out of proportion to any myocardial findings or valvular heart disease findings. Usually you got those patients with that massive lower extremity edema and settings, you're thinking TR, and oh look, the tricuspid valve looks okay. You're going to start to think about constriction. You're going to think about constriction if there's any prior history of chest radiation, and the two most common reasons why people got radiated were breast cancer and Hodgkin's disease, and now we're talking about radiation therapy 20 years ago when they didn't shield as well. And those patients are the ones who are most likely going to get radiation-induced constriction. And you can think constriction when we've been in the chest before. Cardiac surgery sets up an inflammatory process there. If it's the acute phase, use steroids, but if we're talking about someone who had a bypass 5 years ago or a valve surgery 10 years ago, and now they're having right heart findings and their valves look okay, their muscle looks okay, they might have post-cardiac surgery constriction. Moving on to the last section here, and that is recognizing a few things having to do with pericardial cysts, tumors, and metastatic disease in the pericardium. So you'll want to pay attention to Dr. Warren's lecture on an adult congenital heart disease, and you might see chest x-rays that look a little bit like this, but everything else about this, the aortic knob, the pulmonary vessels, everything is fine. Then you've got this thing sticking off the edge here. Your echocardiogram might show a clear space adjacent to the left ventricle. It's not going to look like a giant left ventricle when you do the echo, but what I've shown here is an MRI and showing that this giant white space here between, in this case, the RV and the chest wall, and here wrapping all the way around the apex of the heart are pericardial cysts. These are typically benign. They occur in about 1 out of 100,000 people. The best way to assess them is with a tomographic method like CT or MRI. You mostly leave them alone because they mostly are just incidental findings. But this giant one like this one on the bottom may be impairing cardiac function or motion if it's really big and starts to compress the heart. And if that's the case, then resection tends to be the way to go. They tend to refill or recur if you just try to drain them. Pericardial malignancy has been written in the board's blueprint. Typically, pericardial malignancy is metastatic malignancy from somewhere else. So if you see someone who has a large effusion and a prior history of cancer, you got to think about that first cancer, or you got to think about this, there's a cancer somewhere else that's here that's causing this. And so, as we've said, you're going to want to get fluid in this case because you want to look for cells, and you want to see if there's lung cancer primary. We've seen melanomas in the pericardium, et cetera, but it's typically a pericardial malignancy. You treat that based on symptoms and then treating the underlying cancer. Obviously, you're going to tap it for cells or tap it for tamponade if it recurs. You can use nonsteroidals for pericardial pain. So to wrap up the pericardial disease section, the pearls are recognize that acute pericarditis ECG that Nish had up briefly, which is the elevated diffuse T waves, but they're concave upwards, not convex upwards, and they don't follow a coronary distribution. You're going to start acute pericarditis treatment with colchicine and a nonsteroidal drug. You tap for clinical tamponade, or if you need to make a diagnosis based on cells. And then we had a long discussion about the hemodynamics of constriction and restriction. Thank you very much.
Beautifully said. It's confusing when you say the E velocity goes up here and down here in inspiration and expiration, but I think Steve really did a beautiful job of kind of simplifying it for you so that you can remember everything. So let's start out with this case here. A 63-year-old man presents to the emergency room with pleuritic chest pain, resolves after 5 minutes, recurred several minutes later. He's just kind of felt unwell, viral syndrome, elevated temperature, tachycardia, heart sounds are normal. He's got a normal CKMB, normal troponin, elevation of the white cell count, and SED rate. Which of the following is the next best step? Cardiac MRI, prednisone, indomethacin, or TPA?
Awesome.
They can do it. Okay, so a few other questions on pericarditis. This physical activity you talked about is kind of important.
Yep.
And they were saying, well, how long should they be off physical activity if they have a myocarditis, if they don't have a myocarditis? What do you recommend for your patients?
So anyone who's still having discomfort should not be, they should be at rest. I mean, they can be up and about and those kind of things, but they shouldn't be actively exercising if they're still having pericardial pain. That's usually not much of a problem other than those really devoted exercisers. Most people don't feel like exercising. I think with pericarditis, once they're symptom-free, they can walk, do light activities, those kind of things. But I would let them finish their non-steroidal course before they really engage. If there's someone who's training for an event or they're a super competitive individual, I would make them finish their, not the colchicine, but the non-steroidal part of their therapy before they get super active again. With myocarditis, you want that to be longer. So as they said, it's probably 6 months if they've had fulminant myocarditis that you're going to have them not competing.
So if you take a mouse with myocarditis and you put it in water where it has to swim, they're going to die. Did you know that?
I didn't know. I haven't tried that.
So that, but it just goes to show that if you have a myocarditis, it is dangerous to exercise.
Yeah.
And what about the steroid dose, for this chronic relapsing pericarditis?
So you probably want to start at about 60 of prednisone and keep it stable for a while and then decrease by 10 milligrams a month to begin with until you get to about 20, and then you're going to go down to 5 milligram increments, maybe even 2.5 milligram increments, because again, it's going to be low and slow, that taper, because they do have a tendency to flare, as I mentioned.
Yeah, right when they get to about 12 milligrams, they're going to flare up, so you have to go very, very slowly on those. And it's a difficult situation. The surgery for pericarditis, not constrictive pericarditis, but acute inflammatory pericarditis.
Yeah. I hope you don't have to get there. So it has been done. The success rate is not, it's not the 95% success because these are individuals who still have inflammation that's an issue for them. And yes, you've taken off the pericardium, but they might, now you've been back in their chest. You've set up another reason for them to have inflammation in their chest cavity. And these tend to be the kind of individuals who fall into that atypical chest pain general syndrome, and so they have to be counseled ahead of time that we failed all the other therapies. We're going to try this, but there still may be some discomfort afterwards, and it's one of those chronic syndrome management situations.
Yes, I think what Steve pointed out is very important. Is that especially these young people, who are completely healthy, all of a sudden they get this severe pericarditis. Their sensation of anything going on in their chest markedly changes. Yeah. And they're going to come back with all of this pain, and you're going to have to sort out what's pericardial and what's not. And frequently, they'll have been treated for recurrent pericarditis, and it is not pericardial pain.
Yeah, and that's why doing the CRP is important. So if they don't have markers of inflammation, to help you confirm that it's an inflammatory thing going on. You're not going to want to get all the way to a pericardiectomy to relieve chest pain that's non-inflammatory in nature.
Yeah, or even a MRI scan with
Yep.
gadolinium
Correct.
sometimes is very
Yep.
helpful in those patients.
Yep.
Okay, go to the next question. Pericardiocentesis is recommended for which of the following situations? A post-cardiac operation pericardial effusion with respiratory variation, a young patient with chest pain and a widened mediastinum on chest x-ray, a moderate-sized effusion with normal Doppler flow velocities, normal blood pressure, and markedly elevated sensitive TSH, or a small to moderate effusion in an asymptomatic breast cancer survivor 8 years after the last evidence of disease.
I'm guessing they'll do well on this.
I would hope they'll do well on this. Let's see how well they do on this.
Nice.
Okay. You know, this is the most I've ever heard a session clap
On day one.
on day one.
I know, it's amazing.
They must be pretty good. Okay, any comments on that, Steve?
No, I don't think so. I think with 97%, I think they get it.
Okay. There was a question, though, that came up about the dissection. Why don't you want to tap with a dissection?
Yeah, so again, there are two comments I can make here. The ascending aortic dissection can dissect retrogradely into the pericardial space, and so it just might be a giant hemopericardium, and if you put a needle in there and put up that big vacuum bottle, you're just going to be basically taking blood out of the body. It is the most rapid blood transfusion you're ever going to see, and the patient's going to crump as you start, decompressing their blood volume into your container.
So you take them right to the OR.
You just take them to the OR.
Don't stop, go.
The other thing, and I saw this in the pre-test, there was many of you that chose, a handful of you, I think a quarter, chose the post-cardiac surgery option here. And this again was emphasizing the point that Doppler variation by itself isn't sufficient to warrant a needle in the chest. You either need to have clinical tamponade and or need to get the cells because you're worried about malignancy or something. But just because the Doppler is picking up something doesn't mean if they clinically don't have tamponade that you need to put a needle in there.
Because if you actually do a Doppler post-op, you'll find that many people will have that respiratory variation because there is some pericardial abnormality that goes on there and stuff.
Yep.
And I think the thing that you have to do when you read the echoes is if you start to see the Doppler variation, don't make your diagnosis, but look for that dilated IVC, which is the same as the elevated neck veins that Steve showed, as well as this kind of peculiar septal bounce, which is, you start putting those together, you're going to make the diagnosis, but your point's exactly correct. Don't do it on just the mitral flow velocity curves alone. Okay, let's go to this last group with this constrictive pericarditis. The group that has the worst prognosis, cardiac surgery, rheumatoid arthritis, tuberculosis, or radiation. Boy, they're good.
I think they had 88% to begin with on this one.
Yeah,
though.
but now it's over 95, so you're good.
So,
okay, constrictive pericarditis. The difference between the hemodynamics constriction versus tamponade was one of the things that was asked.
yeah, that's a great question. So the physical exam finding people talk about is the loss of an X descent with tamponade, and that's because
Why descent?
losing the descent
Yeah.
with tamponade, that's because the pressure is equalized within the pericardial sac, and so remember, the X descent is when the atrium's trying to relax, and the Y descent is when the tricuspid valve opens. But that doesn't really change the pressures in tamponade, where everything from the outside is excess pressure pushing on the heart. The volume of the heart is fixed, and so you don't get these descents with tamponade like you do with constriction.
Yeah.
So you see the big descents with constriction, and then you just have high JVP with tamponade.
And then in your Doppler, what that means is that you don't see that rapid early E velocity,
Correct.
but a very low E velocity. So
Correct.
it's a different pathophysiology. And then that brings up the question of this whole concept of effusive constrictive pericarditis. Do you want to talk about that?
Yeah, so the most common spot we see that is post-cardiac surgery. They're going to have a little bit of infusion. It is obviously most humans will try to mount an inflammatory response when their chest has been invaded by a scalpel or other instruments. And this is just an enhanced response for that. And so they get effusion. The pericardium is a little bit edematous. So it gets stiffer and starts to cause some constrictive-like hemodynamics on top of a pericardial effusion. And starting steroids there can be preventative for the late postoperative constrictive pericarditis that we've seen. So if you see someone who is hypotensive, kind of that, just not almost failure to thrive kind of phenomenon after cardiac surgery, and they have effusion and those hemodynamic changes that we talked about, that's a patient who you want to start steroids. If the effusion is really big, you can consider tapping it, but you want to start the steroids and colchicine, if at all possible, to suppress this inflammatory response before it sets up long-term changes.
And even not post-op, but you said that if you do have a diagnosed constrictive pericarditis, let's say without an effusion, you said that the majority should go to surgery, but there are some who might have kind of an inflammatory constriction. Yep. How do you differentiate those patients?
Well, I think for me, it typically is there's some sort of recent event that you can point to. So is it an acute pericarditis that resulted in this effusion that hasn't resolved for your initial therapy? There was someone who just sent me a case this past week where the patient had a bacteremia that was resolved, but now they were having pericardial effusion and constrictive type findings. There's usually an inciting event that you can say, yeah, it makes sense that the human body would respond to and try to heal that in some way that was inflammatory. CRP, SED rates aren't typically elevated in constriction unless the underlying cause is one of the rheumatologic diseases, and then that kind of goes out of the way. But if they don't have those in the background and their markers of inflammation are up and there's an inciting event, then this effusive constrictive becomes an operable diagnosis that you can try to treat.
Yeah, and then sometimes that's where MRI with gadolinium is helpful.
Yeah, absolutely. The MRI is a very useful test that we now have for that.
So if you give gadolinium and they have what Steve's talking about with an inflammation in the pericardium, the pericardium will light up with gadolinium, and those are the patients that actually you'd like to treat with steroids.
Exactly.
Right?
And I think you'll see some cases of that in the imaging section in a couple of nights.
Yep. Okay, 72-year-old woman presents with a new moderate-sized pericardial effusion. She's got hypertension, DJD, and remote breast cancer treated with mastectomy. When do you tap? If there's clinical tamponade, only if the effusion gets larger, you want to tap irrespective for cytology, or you want to treat with high-dose steroids.
They're going to clap on this one, too, because they got it right the first time around.
If they clap, they can go to lunch.
That's a good idea. Oh my goodness.
You guys can't go to lunch. Sorry. Do you want to just talk about that?
So this was that if they've had a cancer before, and in particular breast cancer, because that's the one really bad actor here. If you see an effusion in a woman who's had breast cancer, you've got to prove it's not breast cancer before you go anywhere else, and so you're going to want to tap this one regardless.
Even if it's a small to moderate. I mean,
if it's a small effusion and you don't have a Larry Sinak who can tap anything, you might want to look for other evidence of the breast cancer a different way, but ultimately that's going to have implications on staging, and so you're going to want to try to get the cells from the pericardium. So those of you that said tap only if there's clinical tamponade, I can't say you're wrong because I emphasize that you want to do that in most cases. But when it's cancer, when the patient has a cancer history, and in particular breast cancer, you're going to want to tap that for cells.
Yeah, and I think the point is now people are getting so good using echo-directed pericardial centesis that you could safely do it with a small to moderate, especially if you have good hands.
Yeah.